Hello everyone. Let's start with another topic that is catatonia. It is one of the important topic and I want all of you to focus right from the beginning. And as the word catatonia goes, remember that we need to study everything right from the beginning till how it is at present. So first we'll be beginning of with the historical aspects of catatonia. So as far as the history of catatonia goes, there is one name that you cannot forget, that is this individual that has the picture has been shown over here, and the name is Carl Ludwig Kahlbaum. Okay, so he is one of those important personalities that you cannot forget the name as far as catatonia is concerned. Okay, now if you look into the word catatonia, kata, and this is tonia. Kata means down and tonia means tone. So reduction or fluctuation in tone or tension. Okay. Now, when we look into the timeline, what were the important developments as far as catatonia is concerned? I'll just like all of you to please focus on this particular timeline. Okay. Now, see, first of all, catalepsy was described as a disturbance of brain and nerves by William Andreas. That is what one we should be knowing. Now, Carl Ludwig Kahlbaum later on did something that is called as conceptualization of catatonia. Remember this part. Okay, we should also focus on the work that was done by Hecker and three other person. One of them is Kraepelin for sure. Another one is Bleuler, and then we'll be looking into what were the work that was done by Gellenberg. So let's summarize the historical aspects. Okay, now in the historical aspects, firstly, it is Carl Ludwig Kahlbaum. Carl Ludwig Kahlbaum, he did a very important thing, that is he conceptualized catatonia as a neurological condition with psychiatric manifestation. Remember this. He was the first person to conceptualize this as a neurological condition with psychiatric manifestation. Remember this part. Now, see, he not only conceptualized it, he also gave two different aspects. One is different etiology, and different manifestation of this particular condition known as catatonia. So his work was very much diverse, and he not only conceptualized, rather he gave that what are the different etiology and what are the different manifestation. Okay, he also gave this particular notion that it can present in two very extreme forms, that it can be having psychomotor retardation, stupor, mutism. Okay, and on the other hand, there can be exaltation, increased psychomotor activity, there can be verbigeration, and also there can be atonia in form of posturing, convulsions, and one important word, that is flexibilitas syria. Now, this word, all of this has been discussed properly in psychopathology section in depth. Okay, so just go over there and read the motor system disorder under psychopathology section. But to continue, remember that this was one of the important contribution by Carl Ludwig Kahlbaum. Now, his disciple was Heckler. Hecker, sorry. His disciple was Hecker. Hecker did one important thing. He wrote that catatonia, or in his term, he used to call it as melancholia atonita. Atonita. So this was the term that was used by Hecker. He was the disciple of Kahlbaum, and he mentioned that melancholia atonita or catatonia is having a characteristic course, okay, which includes a series of nosologically important symptoms leading to clear delineation. Okay, clear delineation as a disease. As a disease entity. So this was made very much clear by Hecka that it is a nosologically very different kind of entity and it should be clearly demarcated from other forms of disease. Okay, but this doesn't remain true, and later on, unfortunately, Kraepelin, who like Kahlbaum was a pioneer of descriptive psychiatry. Okay, all of these people who we are learning are definitely experts in the field of descriptive psychiatry. So basically, they used to describe the symptom to the maximum that is possible. So Kraepelin came and subsumed catatonia under the category of dementia precox. Kraepelin, he subsumed catatonia under dementia precox. Okay, which was later renamed schizophrenia by Bleuler. Remember this part. So this particular fact misguided that catatonia is equal to schizophrenia. Remember this. This is the misguiding that was done. Okay, this misguided that catatonia is equal to schizophrenia. And this equation has persisted in modern medicine and has put patient at risk of being administered the treatment that we require, uh, not for catatonia, rather for schizophrenia. See, catatonia itself is a very separate disease, or a very separate disorder with multiple etiology, with multiple manifestation. It is a different entity. Okay, but unfortunately, it was soaked inside the whole big box of schizophrenia. Now, another misstep was done by Bleuler. Bleuler did one more thing. Now, see, in our understanding, of catatonia as a syndrome, it occurred when Bleuler, who emphasized the psychological underpinning of catatonia at the expense of neuromedical explanation. So, psychological underpinnings of catatonia at the expense of neuromedical explanation. Okay. Now, and viewed that and definitely we also have this notion because it has been continuing in our uh, teaching part. And we have been viewing patient with abnormal posture, rigidity, and stupor as purely psychological defense mechanism designed to shut off reality. So this was one of the misguiding that has happened. Okay, so basically it is defined. He put this notion, and now we understand that the clinical features of catatonia is a psychological defense mechanism to shut off reality, because schizophrenia is considered to be a disorder of reality distortion. So it was considered that all the clinical symptoms that is happening in catatonia is basically a defense mechanism to shut off reality. Now, Gellenberg attempted to unearth catatonia from its mooring as a subtype of schizophrenia with purely psychological origins. Okay, so another person that we should be knowing is Gellenberg. Gellenberg, he tried to do, he attempted to untethar catatonia from its mooring as a subtype of schizophrenia with purely psychological origin, and reiterated Kahlbaum's conceptualization of catatonia as a syndrome with multiple manifestation. Gellenberg, along with his colleague Mandel, okay, entangly described catatonia as a biological response to dopamine blockade that may present with psychological withdrawal symptoms to an altered motor system. So, Gallenberg, along with Mandel, they worked on the psychological conceptualization, but they also included motor system alteration or altered motor system. Okay, so these were some of the important things that you should know. Okay, because if you don't know these aspects, then you don't know why we have been studying catatonia as a part of schizophrenia. Very important to know that unfortunately the person who gave the conceptualization later on, because of the interpretation by different set of people, it get subsumed under the broad heading of schizophrenia, and we have been continuing until recently. So this is a brief historical aspect of catatonia that you should know. I know that this part might not be very much helpful for your exams, but to understand catatonia as a different entity, you should be having a solid historical aspect background. Historical aspects not only strengthen your understanding, but will also help you to rectify the mistake that has been done in the previous settings or in by the other set of people. Okay. Now, when we look into the symptoms of catatonia, basically, if we just write this word psychomotor, there are basically three set of symptoms: increased psychomotor, decreased psychomotor, and altered psychomotor. Increased psychomotor symptoms, decreased psychomotor symptoms, and altered psychomotor symptoms. Okay, now this forms the basis in which the symptoms have been categorized in ICD 11, which we can see in this box. Decreased psychomotor activity leading to staring, ambient tendency, negativism, stupor, mutism. Okay, increased psychomotor activity leading to extreme hyperactivity or agitation, extreme emotional reaction, impulsivity, combativeness, and abnormal. It can be seen either in form of grimacing, mannerism, posturing, stereotypy, rigidity, echolalia, echopraxia, verbigeration, waxy flexibility, and catalepsy. So you can see that this is a broad grouping that we can do as far as the symptoms of schizophrenia, catatonia is concerned. Okay, now see, we'll be definitely looking into each of these symptoms in brief so that we can have an idea regarding important clinical features of catatonia. But before we move on, let's look into a comparative table how symptoms are there in ICD-11 and DSM-5. Okay, so basically, if you look, I'll just highlight all the important things. So here also, based on the psychomotor activity, symptoms have been classified. See, based on the psychomotor activity, symptoms have been classified. Now, here you can see that staring is a component of ICD-11 and it is not at all included in DSM-5 or DSM-5 TR. So one thing you should be knowing. Okay, rest, stupor is included in both, mutism is there in both, posturing is there in both. Okay, now these set of symptoms do occur with high frequency, means most commonly these are seen. Next, when we look into symptoms with moderate frequency, ambient tendency, again you can see it is there in ICD, sorry, it is there in ICD 11, but it is not mentioned in DSM-5 TR. So this is again one important symptom that you should be knowing, that it is not mentioned in DSM-5. Rigidity, very important, very important. It is not mentioned in DSM-5 TR, and on the other hand, it is mentioned in ICD-11. Okay, and verbigeration, not mentioned and mentioned. So whenever you are reading, try to have a comparative overview regarding whatever you are reading. So if you can see, these are the four symptoms which are mentioned in four symptoms in ICD-11, which are not mentioned in DSM-5 TR. And the most important ones that you cannot, you know, bet to forget is rigidity. It is one of the important things to remember. Okay, and also staring. Verbigeration is there, ambient tendency, but remember, staring and rigidity is something which you cannot forget. Okay, so remember, it is present in ICD-11, not in DSM-5 or DSM-5 TR. Okay, this is a very important chart that I have taken. Now, let's look into some of the symptoms of catatonia. And when we look into the symptom of catatonia, the first important symptom that is there is mannerism and stereotypy. It is a very common confusion that is being often asked by students, and also it is one of the favorite questions by the examiner that they taper on this particular notion regarding what is the difference between mannerism and stereotypy. This particular article makes it very clear regarding what are the difference between mannerism, stereotypy, and perseveration. Although, if you want to read in detail, you can definitely go back and read it in the psychopathology section. But as of now, let's look into this. See, both the kind of behavior, be it mannerism or stereotypy, can be divided into motor and verbal component. Okay, motor and verbal component. And stereotypy, that is spontaneous or cued. Remember, it is a repetitively abnormal, frequent, non-goal directed movement. Okay, remember, it is a peculiarity of behavior, movement, or posture. Remember this. The very important word is non-goal directed. That is there with stereotypy. Okay, with mannerism, it is a very peculiar behavior, movement, or posture. Similarly, You can see that verbigeration is a type of stereotypy. But in mannerism, it is the peculiarity of speech, language, or slang. Mostly it is related or it is goal directed. This is the part that we have taken it from fish. Okay. And see, stereotypy is related to abnormal act. Mannerism is related to normal act. Okay, normal act, like suppose if someone is doing a salute, salute is a normal act. Okay. And when someone is trying to copy it multiple times or they are doing it on their own, that becomes mannerism because it is a normal act. Okay, it is not an abnormal act. Although the normal act is goal directed, remember it has to be goal directed. If it is non goal directed, it will be counted under stereotypy. See, remnants of goal directed movement can be perceived from both of them. So remember this part. See, so if suppose a goal directed movement, someone is trying to lift their hand and they're not able to complete the salute, suppose they are doing it like this and that, this will be counted under stereotypy because that is an abnormal act and it's non goal directed, it doesn't seem. But you can say that, sir, it can be like that they are trying to make a salute, so they are just lifting it up, but they are not able to complete it. So definitely in stereotypy, you can find that definitely there can be a remnant of that particular goal directed act which they are not able to complete. But remember, these are the two basic differences that you should know. Now, in normal individuals also, you can find that there can be stereotypy and mannerism which is there specifically when a person has to be noticed. Like for example, multiple times you can see that person who wants to flex their watch or their some kind of expensive, or suppose they're wearing some kind of a bracelet or a watch or a ring, something like that, they'll be doing it multiple times like this, like that. Okay, or if a lady is wearing an earring, a very expensive one, she might be doing it multiple times, touching her hair. So these are normal phenomena that can be seen in normal individuals also. Okay, in anxious individuals also, you can see when there is lack of control over motor behavior, they'll do one particular act multiple times. Like for example, just a very important thing, like um, doing like opening and closing their fist. This can be one of the thing. When you become too much anxious, you might do this. Or shaking up of leg, when you ask the person why are you doing so, I don't know why it is happening, just because my motor control is out of my control as of now. It's beyond my control because of the existing anxiety. Now in schizophrenia, it can be seen due to delusional ideas, in catatonia and in form of negativism. Now remember, bizarres, very common word that you'll see is bizarres. Bizarres have been used by multiple people, specifically by the German authors. They say that bizarres are nothing but similar to mannerism. So in German psychiatry, it is having a kind of a very common overlap with mannerism. But others, they say that it is a grotesque, distorted movement, as you can see in the picture that has been described here. You can see the picture that has been mentioned over here. This particular thing, this, okay, over here also you can see. Okay, so this is called as bizarre, in which there is no aim, no goal. Remember, and like for example, here you might say that why is this individual trying to blow out? Others can say no, he might not be blowing out. He might be just a fountain from which the water should come out. He's just doing so, but you don't know basically why this particular individual is doing this particular movement, or just he might be blowing out like this, or just might be teasing the individual who will be looking at this particular structure like, okay. So you don't know the goal or the aim. Now, one thing very important about mannerism, they are diagnostically relevant when it is seen with complete clinical picture. Means you have to look into other set of clinical symptoms along with mannerism itself. It becomes less of diagnostic relevance. But if you look at as a whole, if you fit it in a picture but with other set of clinical symptoms that is there, then definitely it will help you to crack the diagnosis. Okay, remember one more thing, that mannerism is not diagnostic of schizophrenia or any mental disorder. Remember this. Very important point. Okay. Verbal stereotypy. As you have seen in the table, it was mentioned as verbigeration. One condition I would like all of you to focus, that verbigeration is not only seen in schizophrenia or psychosis, but can also be as a part of expressive aphasia. So keep a check on this. It is also having stereotypy as a symptom domain. Okay, now another thing is post grasping. It is seen in catatonia. It is also seen in dementia. So basically, patient receives command. The command that you give is no to touch the hand of examiner. But the individual will still continue to hold it. Okay. Grasp reflex, if you look, yes, grasp reflex. Basically, grasp reflex, it is something that you should focus on. So basically, here the patient automatically catches the object that is placed on hand. So here the command part is not there. Patient automatically catches the object placed in hand. Okay. And one of the ways by which you can examine is draw a line across the palm. Like suppose this is the palm, you can just draw the line with the help of your fingers. Okay. Now, magnet reaction. One of the important thing that you should know. See how it goes on. Touch the palm of the patient, then steadily and gradually you remove away. But you'll see that the patient's hand follows the examiner. Okay. Now, Mitmachen. This is a German term which means cooperation. Okay. Now, see what is happening is, see, the body is put to a particular position. Okay, and the command is, see, the command is to provide resistance to all imposed movement. Okay, so basically you are asking the patient to definitely put resistance to whatever movement is being imposed on the patient itself. But what you'll find that no resistance demonstrated by patient, and once the force is removed, the patient return back to the previous position. Okay, remember this. So it means that you're taking the person from position number one to position number two. Okay, and that is easily done. Gradually, once the force is removed, the person will come back to the initial position. That is why this picture, remember this picture. Okay, you take a person from one state or one position to another position. Okay, and there is no resistance that is shown to the examiner. And once the force is being removed, the position will gradually come back to the initial state. Okay, now a level up to this is mitgehen. Okay, this in German it means to go with. It is actually passive obedience. You can see that multiple times this word has been mentioned for mitgehen, and it is extreme form of cooperation. Okay, the patient moves with slightest of the force. Okay, done by the examiner. Now, remember, Hamilton has given a very specific name to this particular phenomenon, and this is that lamp that all of us should remember, that is called as the Anglepoise lamp. This is the Anglepoise lamp that we are talking about. Okay. Now, if you try to lift it up by just placing a force over here, this, even if it is folded, it will rise up and ultimately get into this particular state. So even if you just apply a brief force over here or a slight of the force, it will open up and come in this force, in this form. That is what is called as Anglepoise lamp. So Midgehen is called Anglepoise lamp phenomenon by Hamilton. Remember this. Now, you must have read about the negative symptoms in catatonia. But remember that there is a symptom domain in which Mitgehen, Wittmarschen, automatic obedience, and eco phenomenon is being described. This is called as positivism. Okay, this particular term is given by Lohr and Wisniewski. So they have described positivism and they consist of four specific symptom domain. Now, what is the next thing? That is advertence. Advertence means the patient turned towards the examiner when approached by examiner. Okay, and does a nonsense act. Nonsense means which is not having any meaning, and the person or the patient continues to do the same act until cut short by examiner. So remember, this is called as advertence. Now, this is a concept box by which you can actually remember the range of symptoms which are there in catatonia. Okay, now see, if we look into the extreme part, that is the first extreme part, that is when we look into the range of cooperation. The range of cooperation, if it is of extreme cooperation, we see that we have automatic obedience, mitgehen, mitmachen. Okay, so basically all the symptoms of positivism is on this particular side. Slight reduction in cooperation, we'll see forced grasping, grasp reflex, magnet reaction. Okay, now in case of plus and minus level of cooperation, at times it is present, at times it is absent. One of the symptom domain which very much fix on this particular aspect is ambitendency. Okay, and on the other side, when there is complete absence of cooperation, you'll find Gegenhalten or negativism and negativism. Okay, so you can understand through this also. Now, when we look into negativism, it is seen in, okay, it is seen not only in catatonia, but also in dementia, in SLD also. Now, it is a motiveless resistance and it is not associated with any defense attitude, okay, and which leads to attenuation of opposition. Now, degree of negativism depends on environment. Okay, now motivated refusal or failure to cooperate is associated with a motive. That is not negativism. Remember this part. That is not negativism. If a person is having a motive and because of that motive there is a refusal or there is a failure to cooperate with particular instruction that is given to him or to her, that is not negativism. Okay, it has to be motiveless. Remember, it has to be motiveless. This is the important term. Now, active negativism, passive negativism. See, active negativism, it means that the patient does exact opposite of what he or she is being asked to do. does exact opposite of what is asked to do in a reflex way. Passive negativism, it means patient resists all interference and no action is being carried out. Now, Gegenholten is also on the other side of the symptom domain. Okay, Gegenholten is basically what we call as paratonia in neurology. Okay, and basically it is an opposite reactive muscle tension. Okay, so basically the patient opposes all movements with same degree of force as what is being applied by the examiner. Remember this term. Now, ambitendency is another important thing. So basically, we can see that whatever symptom we are discussing, concept is there. Okay, it's not just a kind of a, you know, anything that we will be fitting into any of the symptoms. So it has to be what has been mentioned in the standard text. So this is what we are writing. All has been taken from Fish and Sims, details of which is definitely mentioned in the chapter of motor system when in uh, in complete psychopathology series that is there in Final Strike. So go to that segment, you'll be seeing catatonia as a whole different thing. But here, when we look into a disorder level, we have to look into selective portions of that. Now, ambitendency, if we look, see, in ambitendency, there is a hesitant and indecisive movement. Patient is struck. Okay. See, the examiner contradicting his own non-verbal signals. It means, suppose you offer hand, and then once you offer the hand to the patient, you say not to shake. Now, if the patient displays ambi tendency, basically the patient will be in conflict. Okay, to move or to not move. This is called as ambitendency. Now, so basically, if we just frame a, a framework of how to elicit ambitendency, instruction should be given. After the instruction, there will be tentative movements. After which the goal is not reached. Okay. In all of this particular thing that you are going to elicit, patient is expected to act voluntarily. Voluntarily. Remember this. Now, after we have done with the important set of symptoms, we'll see how catatonia has been described in ICD-10, 11, and DSM-5 and DSM-5-TR. Okay. Now, when we see this particular comparison, in ICD-10, it was not a separate disorder. It is a subtype of schizophrenia. And now you know the very basic reason why it has been a part of this, or mood disorder basically. So basically the code that was used was F20.2. Now, ICD-11 made a major change, and it says that catatonia can be diagnosed as a separate standalone disorder and also as a specifier for many disorder in which schizophrenia and mood disorder is also given as a specifier. Now, DSM-5 and DSM-5-TR says that catatonia is a specifier, an associative feature or a separate diagnosis in certain condition. Remember this. It is a specifier. So it can be associated with schizophrenia, it can be associated with mood disorder, it can be associated with mood disorder means mania or in form of depression, but it can also have a separate standalone diagnosis. It was not a standalone diagnosis as for very important point in ICD uh, 10, except for organic catatonia. Remember, organic catatonia F606.1 was one of the diagnoses where you can actually try to fit in, but it was not a standalone diagnosis. It is a standalone diagnosis in ICD-11 and in in DSM-5 and DSM-5-TR. Catatonia associated with other mental disorder is there or due to medical condition, which is a standalone diagnosis. So remember, ICD-11 and DSM-5 have done this particular distinction of giving it a standalone diagnosis. So mostly ICD-10 is historically abiding to whatever we have studied. Now you can make a link between the historical mishappenings that has happened with catatonia and why ICD-10 is like that. Okay, a very narrow outlook of catatonia has been presented. It is broad and modern. It is a very detailed one in DSM-5. Now, diagnostic criteria, no formal standardized criteria was there in ICD-10. Basically, mostly it focused upon motor symptoms, stupor, mutism, posturing, negativism. Here it requires minimum 3 or more than 3 out of 12. And similarly, it has been shown that in DSM-5 also it requires 3 or more than 3 out of 12. And the 12 set of symptoms which are there in ICD-11 is similar to what is mentioned in DSM-5 and DSM-5-TR. Okay, these are the 12 symptoms which are mentioned: stupor, mutism, negativism, posturing, passive flexibility, catalepsy, mannerism, stereotypy, agitation, grimacing, echolalia, echopraxia. Okay, and remember that some of the symptoms which are there mentioned, like for example, staring, you can see that staring and other set of symptoms, like for example, rigidity, which is there, that will you'll not find the similar kind of thing in DSM-5 TR. Okay, that point is there. We have seen that in a previous chart when we discussed it. But remember that more or less similar kind of symptoms have been shared between this ICD-11 and DSM-5. Okay, here you don't have any standardized set of list. Mostly motor symptoms is taken into consideration. Now, you know it, it was placed under schizophrenia, mood disorder, and organic disorder. It is having a standalone code. And yes, this is also in schizophrenia spectrum in as far as DSM-5 is concerned, bipolar, depressive, and catatonia with other mental condition due to mental or medical condition and unspecified. Subtypes, yes, acute catatonia, catatonic schizophrenia. Here, no subtypes are there. Here also, no subtypes. It is basically a specifier which is being used. Here, you require identification of a particular disorder under which catatonia can be placed. That was in ICD 10. You need a diagnosis of schizophrenia or mood disorder unless and until you have an organic catatonia that can be placed under F06.1. You need to have a diagnosis of schizophrenia and mood disorder, then only you can place catatonia under it. Here, not necessarily, it is standalone diagnosis is allowed. Similarly, over here, no specific time duration is being mentioned. Remember this part, very, very important. Inclusion of medical causes. Yes, if you have a medical cause, you have to place it under this particular heading. Here, F06.1, 6A40.1. And in DSM, you can directly place it under catatonia disorder due to other medical condition. Other medical condition. Okay. So that particular thing summarizes how catatonia has been described in ICD-10, ICD-11, and DSM-5. Okay. Now, this is one picture, a very classical picture that has been that you can see across multiple articles in which patients with catatonia they are having different positions, and you can see some of them are putting their hand on top, some of them are lifting their shoes over there on their hand and they're placing it above like this. Some of them are sitting with their legs on top of each other. Okay, so they were helpless. But now, after all of this particular thing, we came to know that how this particular entity was conceptualized, and later on, it got submerged with schizophrenia. But now we are slowly coming back to what it originally was. Okay.